Hello and thank you for joining us today to talk about HER2 testing in metastatic colorectal cancer. The what, why, how, when, and who. I am Dr. Jacqueline Hechtman, Director of Precision Oncology Diagnostics at Miami Cancer Institute and a practicing gastrointestinal pathologist at Baptist Health, as well as a molecular pathologist with NeoGenomics Laboratories. HER2 is an emerging biomarker in colorectal cancer with important therapeutic implications and a wide range of assessment methods. I'm happy to be able to provide you with an overview of this molecular target in today's presentation. This video is sectioned into 5 chapters. Chapter 1 will cover a brief overview of what the HER2 biomarker is, as well as the epidemiology of colorectal cancer, henceforth referred to as CRC. Chapter 2 will explore why it's important to test for HER2 in metastatic CRC. Chapter 3 will explore the current available testing methods for HER2 overexpression and amplification in metastatic CRC. Chapter 4 will describe when in the patient journey it is recommended to test for HER2 overexpression and amplification in CRC. And finally, in Chapter 5, we will provide an overview of the role of pathologists and oncologists in ensuring accurate biomarker testing. Chapter 1. What is HER2 and the epidemiology of CRC? CRC is the 3rd most common cancer and the 2nd most deadly cancer worldwide. There is a high incidence of CRC. In 2022, there was an estimated more than 151,000 new cases of CRC in the United States. Approximately 12% of new cases occurred in patients who were younger than 50 years old, an incidence that has increased by an average of approximately 2% per year from 2015 to 2019. Approximately 50% of patients diagnosed with non-metastatic CRC eventually develop metastases. More than 20% of patients already have distant metastatic disease, that is stage 4 cancer, at initial diagnosis. HER2 overexpression and amplification occurs in a wide range of tumors, including CRC. Most commonly, it occurs in salivary gland carcinomas, followed by breast and gastric cancers, and then CRC, in which the prevalence is up to 5%. But recall that CRC is the 3rd most common type of cancer in the United States, so up to 5% reflects a substantial actual number of patients. The HER2 gene, also known as ERBB2, is a receptor tyrosine kinase and proto-oncogene member of the EGFR family that is essential for cell growth, survival, and differentiation under normal circumstances. Tumors with elevated levels of the HER2 receptor or additional copies of the HER2 gene, referred to as overexpression or amplification respectively, are associated with a faster growth rate. Chapter 2. Why test for HER2 in metastatic CRC? HER2 can form homodimers with other HER2 receptors or heterodimers with other members of the EGFR family. When the HER2 gene is amplified, the HER2 protein is subsequently overexpressed, which results in activation of the PI3K and MAPK pathways and leads to unchecked tumor growth. Additionally, HER2 activating missense mutations occur at certain hotspots in the extracellular or kinase domains, and they can activate HER2 pathways even without HER2 gene amplification, thus driving tumor progression through increased cell proliferation and survival. We now know that HER2-positive disease, that is, HER2 overexpression and amplification, occurs in 3 to 5% of patients with metastatic CRC. Several studies have shown that HER2 positivity in RAS wild-type metastatic CRC may be a predictor of decreased clinical benefit with EGFR inhibitor therapy, which we will discuss in more depth shortly. Here you can see there are several mutations that can arise in metastatic CRC that may be associated with primary resistance to anti-EGFR therapies, underscoring the importance of accurate assessment of biomarker status before initiation of treatment. Let's take a look at a study assessing response to anti-EGFR therapy in patients with HER2 amplification. A 2019 cohort study investigated EGFR inhibitors in patients who were previously treated and diagnosed with metastatic CRC that was either HER2 amplified or not HER2 amplified. This study demonstrated that patients with HER2 amplified metastatic CRC experienced significantly shorter median progression-free survival compared with those without HER2 amplified disease. That's 2.8 months compared with 8.1 months respectively. These data show that EGFR inhibitors may not be as effective in patients with HER2 positive metastatic CRC, underscoring the need to use alternative therapy approaches in this population. Here we see data from a real-world retrospective study that found that patients with HER2-positive metastatic CRC who were treated with an anti-HER2 treatment regimen had a 4.6-month longer median time to next therapy than those not treated with a HER2-targeted therapy. These studies and others suggest that HER2 is a biomarker with therapeutic implications in metastatic CRC. HER2 has become a key therapeutic target in metastatic CRC. With a wide range of studies that have been investigating the biomarker, there's potential to address the unmet need for more effective therapies in these patients. I also want to bring to your attention the range of testing methods and HER2 positivity criteria used in these trials, which we will discuss in more depth shortly. In general, the predominant methods are immunohistochemistry, or IHC, for detecting HER2 overexpression with reflex in situ hybridization, or ISH, or separately next-generation sequencing, or NGS, for detecting HER2 amplification. But you can see the criteria varies from trial to trial. Chapter 3. How to test for HER2 overexpression and amplification in metastatic CRC. Although HER2 is an emerging biomarker in metastatic CRC, it is a well-established target in breast and gastric cancers. In fact, there are already standard HER2 scoring systems associated with breast cancer and gastric cancer, which are used to identify those patients who might benefit most from HER2-directed therapies. The NCCN guidelines have now expanded their recommendations to support routine HER2 testing in patients with unresectable or metastatic CRC. There are differences, however, in the HER2 scoring algorithms between breast and gastric cancers. Let's go over the breast scoring algorithm first, as outlined by the NCCN guidelines, ASCO, and CAP. HER2 testing is recommended to be performed on all new primary or newly metastatic breast cancers. A score of 0 or 1+ on an IHC test denotes a negative result and is identified when there is no membrane staining or membrane staining that is barely perceptible in 10% or less of the tumor cells, or incomplete membrane staining that is barely perceptible in more than 10% of tumor cells. An IHC score of 2+ denotes an equivocal result for overexpression, defined by weak to moderate but complete membrane staining in more than 10% of tumor cells. Equivocal IHC results should be reflex to ISH testing, which we will discuss in more detail shortly. Positive IHC result is denoted by a score of 3+ and is identified when complete, intense, circumferential membrane staining is observed at a low power in more than 10% of tumor cells. So not laterally U-shaped, the whole membrane must show the staining. Now let's look at the gastric cancer IHC scoring algorithm as outlined by ASCO and CAP. HER2 testing should be performed on patients with advanced recurrent or metastatic gastric cancer for whom HER2 targeted therapy is being considered. As you will see, the IHC HER2 scoring is the same as for breast. 0 or 1+ for negative, 2+ for equivocal, and 3+ for positive. A key divergence between the gastric and breast scoring systems is that the gastric scoring system provides separate guidance whether the sample is a surgical or biopsy specimen, and the main difference in the scoring criteria are how HER2 positivity is determined for the gastric biopsies due to the biological heterogeneity of gastric tumors. In gastric cancer, similar to breast cancer, IHC scores of 2+ denote an equivocal result for HER2 overexpression and should be reflexed to a validated fluorescence in situ hybridization, or FISH assay, a particular technique of ISH involving fluorescence microscopy. This technique uses dual probes of HER2 and chromosome enumeration probe 17, or CEP17, which are both on chromosome 17. FISH visualizes the number of HER2 gene signals compared with the number of CEP17 signals. If the ratio of HER2 gene signals to CEP17 signals is more than 2, this confirms HER2 amplification. HER2 amplification can also be identified if the average number of HER2 gene copies is greater than or equal to 6 signals per cell, regardless of the number of copies of CEP17. Guidelines provide slightly different recommendations for what is considered positive or negative for HER2 by FISH, which are outlined here, but all include some combination of these two FISH approaches for confirming HER2 positivity. HER2 biomarker testing in metastatic CRC is recommended by the NCCN guidelines, unless the tumor is known to have a KRAS, NRAS, or BRAF mutation, as these mutations sometimes co-occur with HER2 overexpression and amplification. HER2 testing methods used in metastatic CRC are IHC with reflex FISH and NGS. We will discuss these methods in more detail. Given that HER2 is a somewhat new biomarker for CRC, there is no consensus for HER2 positivity criteria, unlike in breast or gastric cancer. The criteria used to define HER2 positivity has varied across trials, as you can see here. However, the testing methods used in these trials consistently include IHC with FISH confirmation for equivocal results and/or NGS. We have discussed IHC in terms of breast and gastric cancers, and similarly in CRC, an IHC score of 3+ or an IHC score of 2+ with FISH positivity confirmation indicates HER2 overexpression. whereas a score of 1 plus or 0 denotes a tumor negative for HER2 overexpression. This technique is a semi-quantitative measure of HER2 overexpression, and it measures the relative number of HER2 receptors on the surface of cells. Here are some visualizations of different HER2 intensity expressions with IHC. An intensity of 0 means no expression is detected at any power. 1 plus expression is detectable at 400 times original magnification or a 40x lens. A 2 plus expression is generally detectable at 100 to 200 times original magnification, so lens of 10 to 20x. And 3 plus expression should be visible at low power with a 2 to 4x lens. As we have seen, multiple testing methodologies are used for HER2 in metastatic CRC, and there are also multiple IHC scoring criteria used for identification of HER2 positivity in metastatic CRC. At ASCO GI 2023, investigators from the Mountaineer trial, which evaluated the combination of tucatinib and trastuzumab, presented data from a concordance analysis comparing breast and gastric HER2 scoring algorithms in the mCRC setting. Using FDA-approved assays, tissue samples were scored by both breast and gastric algorithms for HER2 IHC. In this table, you can see that investigators found 100% concordance between the breast and gastric algorithms in HER2 status, as well as a 99% concordance in HER2 IHC score. This analysis supports the use of either algorithm for identifying HER2-positive metastatic CRC tumors until an FDA-approved assay is available for metastatic CRC. FISH identifies HER2 amplification by measuring the number of copies of the HER2 gene present in a cell and is typically used to confirm equivocal IHC results, as discussed. So as discussed, when the IHC is 2 plus or equivocal, the specimen is reflexed to FISH, and you have the option to use a single probe of HER2 only, or a dual probe of HER2 compared with CEP17. However, dual probe is more common and it is recommended. In this image, we can see an example of what the HER2 with CEP17 FISH visualization looks like. In red, we have HER2 while CEP17 is in green. In the far right image, we can see there is a multitude of red signals per cell, with only around 2 green signals, which is characteristic of amplification. Additionally, if the ratio of HER2 to CEP17 signals is less than 2, but there is an average of 6 HER2 signals per cell or more, that is also considered positive for HER2 amplification. The third and newest is NGS, which can detect many variations and mutations in a cell, including HER2 amplification. However, it is important to mention that not all NGS panels include HER2 amplification by default. So if you are choosing NGS, unless it is a large hybridization-based panel, it may be necessary to request HER2 IHC separately. Recently, HER2 amplification has been increasingly assessed by tissue-based NGS. While both FISH and NGS look at DNA, NGS assesses the number of HER2 gene copies against the number of copies of various other reference genes in a panel, rather than against a single comparator such as CEP17. The genome assessed in this plot shows HER2 amplification as identified by the red regions. NGS panels use various software programs to assess gene amplification. It is important to keep in mind, however, that NGS can underestimate the level of HER2 amplification due to the tumor cell extraction process, which allows for the presence of lymphocytes and stromal cells. Furthermore, since the tumor cells are not directly visualized with this process, tumor heterogeneity may confound the results, in contrast to IHC or FISH. Studies have shown that HER2 amplification may also be detected in circulating tumor DNA, which I will refer to as ctDNA. However, at this point, ctDNA assessment is not the standard method for HER2 assessment, especially in metastatic CRC. At the current time, the main use of ctDNA for CRC is the detection of minimal residual disease after curative intent resection for stage 2 to 3 CRC. ctDNA is sequenced using plasma-based NGS and assessed in a manner similar to that of tissue-based NGS. It may be less sensitive for cases of lower disease burden, for example, in oligometastatic disease or when there is an ample amount of heterogeneity, since you are not able to directly visualize the extent of overexpression as you can with IHC and FISH methods. As of now, in relation to HER2, ctDNA assessment is often used as a method in clinical trials to track the course of disease while patients are on HER2 inhibitor therapy. As we have seen, these testing methods for HER2 status have their own advantages and disadvantages. IHC, which is the most common approach, is inexpensive, quick, and accessible with only one slide of the tumor sample required and no minimum tumor purity needed. Additionally, tumor heterogeneity does not preclude analysis as you are able to directly visualize the tumor cells. The disadvantages with IHC lie with variability in inter-observer interpretation, processing protocols across labs, fixation time, and tissue thickness. FISH is slightly more expensive and time-consuming than IHC, requiring specialized equipment for visualization. However, it is quantitative, has its own internal assay control with no minimum tumor purity required, and accounts for tumor heterogeneity as you can directly visualize the cells. Tissue-based NGS has the longest turnaround time and it's more costly than other methods, yet assesses other important molecular biomarkers. In a large enough panel, you can test for the other targets such as KRAS and NRAS extended testing, BRAF mutation status, and microsatellite instability status at the same time as HER2 amplification status. However, remember that tumor heterogeneity cannot be assessed on NGS. For example, if you have 20% of cells with low-level amplification, there is a chance that HER2 amplification may be missed with this method. The last method, ctDNA-based NGS, is not yet a standard method for HER2 assessment in metastatic CRC. Chapter 4. When to test for HER2 in metastatic CRC. The NCCN guidelines recommend testing for different biomarkers at different times during the patient journey. For instance, the NCCN recommends testing for mismatch repair or microsatellite instability status at the diagnosis of CRC, regardless of the stage. The guidance changes for other biomarkers. NCCN guidelines recommend testing for HER2 at diagnosis of metastatic CRC, along with KRAS, NRAS mutations, and BRAF mutations. I want to reiterate that given the therapeutic implications of HER2, ideally HER2 biomarker testing should be performed simultaneously with other actionable biomarkers to help guide treatment decisions. Chapter 5. Who tests for HER2? The importance of multidisciplinary collaboration. As HER2 testing in CRC evolves, it is essential for pathologists and oncologists to collaborate beginning at diagnosis of metastatic disease and throughout the disease course, communicate about biomarker testing workflows, and stay up to date on biomarker guidance as they evolve. Pathologists are crucial partners for oncologists during testing decisions as they can help guide on which assays should be used, which specimen types are best for which tests, how much tissue is necessary for HER2 testing or based on the tissue available, and which test might work best to ensure that the right test is being performed and the most accurate results are obtained. Medical oncologists work with the pathologist to order the biomarker testing for the biopsy or resected tissue, as well as work with a broader multidisciplinary team to use biomarker information to determine how these results can guide treatment decisions. Importantly, by working together, pathologists and oncologists, along with a multidisciplinary disease management team, can help establish institutional guidelines or reflex workflows that guarantee patients receive biomarker testing, which is still lacking in many institutions. In summary, we hope that you have learned today that HER2 overexpression and amplification is a biomarker with therapeutic implications for patients with metastatic CRC. This biomarker is found in up to 5% of all patients with metastatic CRC. These patients may not respond as well to EGFR inhibitors, but have been shown to benefit from HER2-directed therapies. The NCCN guidelines recommend testing for HER2 overexpression and amplification at diagnosis of metastatic CRC, among other clinically relevant biomarkers, as these results can help guide physicians' treatment decisions toward the most effective therapies for the specific mutations. There are several methods of HER2 testing and HER2 scoring criteria available. It can be overwhelming to choose from the wide range of options, but remember to consider the advantages and disadvantages of each and use what fits best with your practice and the specimen you have available. As interpretation criteria for HER2 testing in metastatic CRC continue to evolve, remember that a strong concordance between the breast and gastric HER2 IHC scoring algorithms has been demonstrated for HER2 scoring in metastatic CRC. Before we close, I want to encourage you to proactively take the information from this presentation back to your multidisciplinary disease management team, so as a field, we can establish routine HER2 testing for patients diagnosed with metastatic CRC across institutional practices and ensure patients are receiving the treatment they need. Thank you very much for watching this presentation about HER2 testing in metastatic CRC.